Let us turn back to our program, please. We're going to look to our keynote, Innovations in Indigenous Health Workforce Development. And our speaker is an Oglala Lakota tribal member from Pine Ridge, South Dakota. He comes from a long line of traditional healers and medicine men in his community. Received his medical degree from Stanford and his master's in public health from Harvard. And he serves as the co-director of the Center for Indigenous Health and is a tenured full professor at Bloomberg School of Public Health at Johns Hopkins institutions, which are, of course, stellar in each and every way. Please help me welcome Dr. Donald Warne.
Thank you. Yep. How mitakiapi, pilami ayelo, Donald Warne machiapi, prejuta wichasha lakota machiapi, lila wopi latanka. Hello, thank you and welcome to all my relatives here today. I'm so deeply honored to be a part of these important discussions and also so deeply honored to be welcomed on your homelands to have this discussion. I really appreciate the theme for the conference, looking at gathering wisdom and honoring our shared vision through culture and tradition. And I've been very fortunate in my own career as a physician to start my training really at a very young age, focused on traditional medicine and culturally based medicine. And I've worked over the last now 30 years as a physician, focusing on Indigenous health in various capacities. I've been a primary care doctor working with Indian Health Service. I've also worked with tribal programs as a public health director and various roles in academics and advocacy. I'm currently the co-director of our Center for Indigenous Health at Johns Hopkins University, and we've been doing a lot of work over the last 3 decades now, trying to improve Indigenous health. And one of the things that I've observed in my own career, and I'm sure many of you have experienced this, is that the way we're trained in medicine, public health, and in other health disciplines was not designed by us or for us, generally speaking. So we have a colonized approach to medical training and to workforce development. And we can change that. It's something that we need to change and something I've been working on over the last few years. So just deeply honored to be able to share some thoughts with you today. So I'll cover 3 main areas. One, an overview of our Center for Indigenous Health. And we have a new Doctor of Public Health in Indigenous Health that we'll be offering through Johns Hopkins. So it will be the first DRPH in the world with an Indigenous health specialization. And I'm always recruiting students, so it's part-time and asynchronous, so you can be anywhere in the world and actually complete this doctorate in public health. I'll also talk about some of my own experience in training in Indigenous healing, but also in medicine as a physician, and how those worlds in many ways are different, but they can be brought together in meaningful ways. And when we bring the worlds together, I think we see a lot of synergy and a lot of potential for improving healing outcomes. And then we'll talk about future opportunities, including an exciting project that we've been working on now for a few years called the Indigenous School of Medicine. So we'll talk about that as well. So we'll start out with just the background of our Center for Indigenous Health. It was founded in 1991 at the Bloomberg School of Public Health, and the original director is Dr. Mathu Santosham. And he's a pediatric infectious disease physician. He's in his 80s and still working with us as an emeritus director. But the reason he became interested in American Indian health is that as an infectious disease doctor, he and a team from Johns Hopkins were called to respond to an outbreak of viral infectious diarrhea in a tribal community in Arizona. And it was just terrible. These young children were dying from dehydration because for those of us who work in clinical medicine, trying to start an IV in a dehydrated child is difficult in the best of circumstances. But when it's a rural, impoverished community, it's even more difficult to try to get IV fluids. So this team went out to this tribe in Arizona to develop an oral rehydration solution, and that became Pedialyte. So if you've ever used Pedialyte, it actually has its origins in the Johns Hopkins Center for Indigenous Health. And it's estimated that Pedialyte worldwide has now saved hundreds of thousands of lives, because it's not just in our Indigenous communities where this can be a challenge. So over the last now more than 30 years, our focus is to work in partnership with communities to advance Indigenous well-being and health leadership to the highest level. And as I had mentioned, we have the DRPH in Indigenous health that will be starting next year, but we've had training programs now for a couple of decades, and we've had hundreds of students come through our training programs. And our vision is thriving Indigenous communities worldwide. So most of our work has been in the States, but we've expanded some of our work to other parts of the world as well. So in terms of some of the major accomplishments through the center, I had mentioned Pedialyte, the oral rehydration solution, but also through our research and our close collaborations with tribal communities, we've also participated in 4 of the 9 currently recommended childhood vaccines in the United States. One of them is Hib, Haemophilus influenza B. You may have heard of Hib. And when I was going through my training in medical school, starting in 1990, I had learned about Haemophilus influenza B, and it's a bacteria that can cause meningitis or epiglottitis. And when children would get this disease, they would literally choke to death on their own epiglottis. And it was just horrible, horrible suffering that these children went through, and it was fatal. It was a really awful disease. And then the Hib vaccine came out, and in my training and in my career, I never saw one case of Haemophilus influenza B because of the success of those vaccines. As I understand it, there was a case recently because of the anti-vaccine movement that's going on in the States. I don't know if that's happening here, but it's really unfortunate to see. But our tribes actually participated in those studies, and we proved how effective those can be. And from a public health perspective, that's really saved a lot of lives. We also have a home visiting program for maternal, child, and family health called Family Spirit. And this is a program where we have home visitors going into the homes, or basically community health workers, and identifying high-risk pregnancies, but then working with those families all the way through age 5 for the child. And it's now an evidence-based practice that's proven to improve outcomes for both the babies and the moms and the families. And it's a holistic curriculum that can be modified to different cultures. And a couple of years ago, we received a large grant from the Lego Foundation. So Lego the toys, they actually have a foundation. I didn't know they had a foundation until the grant opportunity came out. But it actually was a huge grant. It was $30 million to expand Family Spirit to communities in Canada, Australia, and New Zealand. So we've been very honored to work with some of your communities here and expand this type of work to other parts of the world. We also have a National Institutes of Health funded Center of Excellence focusing on strengths-based substance use prevention. And I think when we deal with these challenges related to addiction and substance use, quite often we're using the kind of the colonizers' Western standards or approach to addiction. And what I've seen in my own career, and I'm sure many of you have seen this as well, is that there's this tendency to blame the victims, to blame the people who are suffering through addiction. And that's not our way. I think we have this common experience of intergenerational trauma, and people are self-medicating that trauma. And it's not just about blaming or categorizing an addiction as much as it is focusing on the strengths of our culture, which is why I really love the theme of this conference. But also it was wonderful, the event last night, to raise funds to do exactly that, right? Strengths-based wellness promotion and substance abuse prevention. And we also have the largest Indigenous training and scholarship program in public health in the United States. We've now trained several hundred Indigenous peoples in public health programs. So our work is really focused in 4 core areas: policy and advocacy, recognizing that we have to have our own unique policy development to address American Indian health. And I know that's true here, that in Canada, there's a different system of medicine, obviously, than we have in the States, but it never has enough resources, and it's not always culturally relevant or culturally appropriate, right? So we have to be able to develop programs and advocate for those programs that are much more meaningful to tribal sovereignty and to tribal cultures. We do a lot of research and evaluation, but our research is focused on community-based priorities. We've completed a few projects where we've developed community-driven research priorities. And these are really valuable things to do because quite often the information we get from the communities is much more rich and much more applicable than what we might just think of as scientists working in a university. As a quick example of that, we worked with our Great Plains Behavioral Health Directors Association. And one of the programs was incorporating what they call ceremony-assisted treatment. You may have heard of medication-assisted treatment for things like opioid addiction. And rather than just focusing on the medications, this program is doing ceremonies. So it's a 12-week curriculum with 6 Lakota ceremonies. And the data are just compelling. The outcomes are much better when we incorporate culture, tradition, and ceremony and language and land-based healing into the recovery programs. And I think a lot of us just intuitively know that, right? That that's the way we should be approaching things. But it was wonderful. The traditional healers in this program asked us to study it because they were recognizing that it's effective and we need more resources to support that type of work. We also have borrowed a term from Canada, the wise practices approach. In the US, we do a lot of work focused on evidence-based practices or best practices. But every time I hear the term evidence-based practice, my question is always, whose evidence is it, right? Because if there's a program working very effectively in Toronto, does that mean it's going to work effectively in a small First Nations community in a more rural area? And it might work, but it certainly would need to be culturally adapted. So we have a whole area of work looking at cultural adaptation of best practices. And we need to use the local languages and local norms, local culture, local ceremony, local champions, local experts, local elders. So we can't just take programs off the shelf and assume that they'll be effective in our communities. We need to be smarter about that. So we have a whole body of work looking at Indigenous implementation science. And then finally, education and training. I'd mentioned we have a lot of graduate students, Master of Public Health, PhD, and Doctorate of Public Health students, and just very excited about the brand new DRPH in Indigenous Health. So I mentioned we're from Johns Hopkins University, which is located in Baltimore, Maryland. So that's the East Coast hub that we have. We have over 350 employees now for the center, but only about 20 or so live in Baltimore. The rest of us are working out in the field. So our largest hub is in the Southwest. We have several offices in Arizona and New Mexico. We have a hub in the Great Lakes called the Great Lakes Hub, and it's in Duluth, Minnesota. And as I'd mentioned, the brand new center is where I live in Rapid City, South Dakota. That's the Great Plains Hub. So that's kind of the background of our center, and how is it that I came to this work and am interested in integrating culture, tradition, and modern medical science. This is a picture of 2 of my great-great-grandfathers. I feel very fortunate that I have pictures of 2 of them, so these are great-great-grandfathers. On the left, that's Chief Stabber, and he was one of the Lakota leaders who went to Washington, D.C. as a delegation of tribal leaders. And this was in 1872 when that picture was taken in Washington, D.C. And I just look at him and how brilliant he looks and just beautiful. And I also think about how much courage that must have taken to essentially go to what was a foreign land, to Washington, D.C. from the Dakotas, and then to try to advocate on behalf of his people. And then the dependence on working with the Ieshkas, the interpreters. So he was speaking Lakota. They had to trust that the interpreter was speaking appropriate English, and then back the other direction, English from the federal government, and then being interpreted back. So it was a challenging time, obviously, for all First Nations and American Indian populations. And one of my elders kind of explained this picture. You can see his right braid is covered in the red cloth, and on the left side, it's still open. And what that symbolizes is that they were not done negotiating. They were not complete with their discussions and their settlements. So he was right in the middle of these negotiations, and at this point in time in 1872 had his picture taken. So that's Chief Stabber. One of my other great-great-grandfathers on the right, that's Kills on Horseback was his name. And very different circumstance. He was actually part of the Buffalo Bill Wild West show that used to tour in England and other parts of Europe. So this was from the 1880s or 1890s, and that picture was actually taken in Europe. But when we look at my own family tree and line, Chief Stabber had a son named Crandall Stabber. Crandall had a son named Louis Stabber, and his daughter was Beverly, which is my mother. And then Kills on Horseback had a daughter named Eliza, who married a Bissonette, and then they had a daughter named Eva, and that was my grandmother. So it's my connectivity to the great-great-grandparents. And I felt very fortunate to come from this family because it's a family of healers. My grandfather Louis was a medicine man, And my Lakota name is Prejuta Wichasha, which means medicine man. I was named after my grandfather, Louis, in a traditional ceremony. And my mother, Beverly, unfortunately passed away last year. She was 85, but she worked as a nurse her entire career. So I was kind of immersed in understanding healthcare from multiple perspectives, both the traditional Lakota way, but also modern medicine and modern nursing. I'd mentioned my naming ceremony when I was 18 or 19 years old. I was given my grandfather's Lakota name, Prejuta Wichasha. And it was so long ago, I actually had black hair. That's how long ago that was, so many, many years ago. But this is at our ceremony grounds in Kyle, South Dakota. And the other name for Kyle is Prejuta Haka, which means medicine root. So I come from the Medicine Root District of South Dakota. And this is our ceremony grounds in Medicine Root District. And where all the trees are, that's the Medicine Root Creek that goes right through our family's land. It's just a beautiful place. And I just feel so blessed and fortunate that I grew up in a family closely connected to culture and ceremony, because that's provided a strong platform and a basis from which to do all of this work. That when I think about medicine and healing, this is what I think about. I don't think about hospitals and pharmacies and pills. I think about ceremony, I think about culture, and all of the healing that occurs when we're closely connected to this. And again, that's why I really appreciate the theme for this conference. It's just wonderful that we have these commonalities around tradition and honoring ceremony and culture. This is one of my uncles, Virgil Killstraight, and he was our Sundance leader for many, many years. I'd first gone to Sundance when I was about 18. I'm 58 now, so about 40 years I've been going to ceremony back home in South Dakota. And unfortunately, Virgil passed away a few years ago, but he was just a remarkable traditional healer and our Sundance chief for many, many years. And I learned a lot of lessons from him and learned about the responsibility that we all carry as Indigenous peoples who have the ability to be in leadership roles and the ability to help our people. That it always has to be about the communities. It has to be about service to others, not about personal gain. And I just learned a lot of wonderful lessons from my Uncle Virgil. So I was going through my training in traditional medicine starting as a young man, but I was doing well in college. So I was at Arizona State University for undergraduate training, and I was being encouraged to go into pre-med curriculum. For whatever reason, the sciences came relatively easy to me. Through no work of my own, I was just fortunate that it just kind of made sense logically. So I was lucky that there was a pre-med advisor on faculty at Arizona State University, and he was trying to diversify the pre-med club. So he asked if I had ever thought about going into medical school. And my first question was, are there any Indian doctors? Because I had actually never met one before. And it made me realize over the years how powerful it is to have role models, right? I think if you're from the majority society, all of your doctors, all of your teachers, all of your principals, all the professionals you engage, if they're from your race or ethnicity, then anything seems possible. But a lot of our kids grow up never seeing that, right? They don't have people from our own cultures or the physicians or the principals of schools and that type of thing. So this is actually my graduation from medical school. So this picture was taken June 15th of 1995. So next week it'll be exactly 30 years that I graduated from medical school. Thank you very much. So I've been able, again, just to be very fortunate to understand in a deep-rooted way traditional, culturally based Lakota medicine, but also scientific and modern medicine. And when I think about these things, they are not mutually exclusive, but I see modern medicine as one tool within a much broader toolbox. And what we're taught in Lakota, and I know in many of the traditional systems here, is the idea of a sacred hoop or a circle or a medicine wheel. And we look at health as being balanced among 4 directions: spiritual to the east, mental to the north, physical to the west, and emotional to the south. And what I've realized is that my training as a physician really is focused on physical health. So physician and physical have the same Latin root, physic, meaning the natural sciences. So as a physician, we're saying it right up front, we deal in the physical arena. And what I found is that if the illness that we're treating is rooted just in the physical realm, allopathic medicine tends to work pretty well. So if we have high blood pressure, antihypertensives work pretty well. If we have inflammation, anti-inflammatories tend to work pretty well. But what if we have deep-rooted spiritual and emotional trauma that's leading to self-medication and addiction? Is there a pill that's going to fix that? Well, of course not. And we have to look at things more holistically. And I think that the tools we have available to us as physicians are tremendous, but they don't apply to everything. And I like that old saying that if your only tool is a hammer, every problem becomes a nail, right? And that's how I see modern medicine. We're just taking a hammer to everything and wondering why it's not working. Well, it must be the patient's fault, right? It must be the community's fault. No, maybe it's the problem with the approach that we're taking. And when I think about traditional medicine, we do physical medicine. We have herbal remedies that are used for physical ailments. For example, anybody know what medication comes from willow bark? Anybody know? Very good, aspirin. So we use aspirin all the time, and that's willow bark tea is the way we've used it for thousands of years. So willow bark tea was a traditional medicine for thousands of years until Bayer discovered it, and now it's a modern medicine, right? So sometimes I'm asked, are there any hospitals that are doing a good job of integrating traditional indigenous medicine? And my answer is yes, every single one of them. Because if you go to the emergency room and they suspect a heart attack, what's the first thing they do? They give you willow bark tea, but in this case in the form of aspirin, right? Well, that's our medicine, right? That does not belong to the colonizers. That's actually our way of healing. And there's actually hundreds of examples of medicines that we use in modern times that have their roots, quite literally, in indigenous medicine. So I see the role for being a physician as being a part of a much broader picture of culturally based healing. And I think that in modern medicine, there's a sense of arrogance, quite honestly, that it's the best way of healing, that it knows more than any other system. And that's what I was exposed to in my own training. So when I was working more as a full-time clinician, I would be asked, how do you incorporate traditional medicine into your modern practice? And my answer was, I don't. I incorporate modern medicine into my traditional practice because the traditional practice is much bigger. Yeah, thank you very much, appreciate that. So we also have to recognize that all of us have mental and health and the things we think about, but also emotional health and the things that we feel, but also spiritual health. And in my own training, the only time the word spirituality came up in my modern medical training was when I was doing my hospice rotation. So we had to wait until there was an impending death before we even used the word spirituality. Well, spirituality is not just about the dying process, right? It's about the living process, but it's not incorporated into modern medicine nearly as well as it could be or should be. So I really look at this model as a way to understand holistic healing, but our medical training systems do not do this, right? So we need to look at more innovative ways of bringing these worlds together more effectively. So I'd mentioned I've worked in health and education and research for many years now. And I've worked in several medical schools and public health schools. And what I see is that there's a lot of indigenous knowledge, like willow bark tea, but there's also a lot of modern science that's wonderful, that is really useful for us. And in truth, they're not separate arenas. It's more like a Venn diagram, right? There's overlap where we have indigenous knowledge that's incorporated into modern science, but we also have modern science that can now be incorporated into traditional healing. And what I see is that the worlds are very separate when it comes to training for the next generation of healers. We have wonderful systems of apprenticeship and training our future medicine men and medicine women from a cultural perspective. And we have medical schools where we're training doctors to become physicians. But those worlds need to be brought together. And that's, I think, the next phase of what we really need to do. And I think modern medicine needs to recognize that indigenous peoples have always been scientists. We've always done science, technology, engineering, medicine. That is who we are. It's part of who we are as indigenous peoples. We've always been researchers. We've always been evaluators. We've always been scientists. So it's not a foreign arena. So I've been spending a lot of time looking at this and thinking about this, and just thinking about the Americas and indigenous peoples here in North America and South America. This is actually a picture of a Mayan city in Guatemala. And you may have seen there was a really good documentary on National Geographic looking at the Mayan megacities. If you ever want to Google that, it's an amazing story. But underneath these, the jungle now are these huge cities. And they were much more advanced technologically and much larger than any city in Europe at that time in history. So our advancements in technology and engineering were beyond anything going on in Europe at that time in history. I had mentioned willow, right? This is a willow tree, and we knew that this was medicinal, and we've been using it as a medicinal tea or aspirin for thousands of years. For those who've worked in a hospital, you might be familiar with the bulb syringe. Now it's kind of a blue, kind of plasticky a device that we use as a bulb syringe. The original bulb syringe is indigenous. So this was a bulb syringe that was made with a small animal bladder and a bird bone. And they use it basically the same technology that we use in the hospital now. But that's ours. And what's really remarkable, the Inca people, they were the first to have successful brain surgery. So when there's a closed head injury, what can kill people is that intracranial pressure. There's too much pressure inside the skull. So even in modern medicine, the surgery is called a burr hole, where they create a hole to relieve the pressure. So they found dozens of these skulls of indigenous people, the Inca tribe in particular. And we know that they survived the procedure because you can see healing around the bone where the hole was made. Isn't that amazing? Original brain surgery was indigenous people's process, not just the colonizers. But the colonizers don't understand this and certainly don't respect it. I've, in my own experience, seen so much disrespect for traditional medicine within the scientific community. And one of the big challenges is we just don't have enough of our own people who are the deans of medical school. I'm not sure what the numbers are in Canada, but in the US, can anyone guess how many medical school deans are American Indian in the United States? It's even less than one, it's 0. So you can count them on 0 hands is how many we have. So that's one of our big challenges. We're just underrepresented in medicine, but we're unrepresented in medical education leadership. And those things need to change. So I'm sure many of you have seen this type of an image before, looking at the difference between equality and equity. And within a framework of equality, everyone gets the same services. Everyone gets the same medication plan. Everyone gets the same curriculum, right? Whether or not it meets your needs, everyone gets the same process, the same means. But that's not achieving the outcomes that we are looking for. Through an equity lens, we're looking at the outcomes, not just the process. And we recognize that there are individuals and there are cultures and there are communities that might need unique and specific types of interventions. Like I had mentioned, ceremony-assisted treatment. That's highly effective for our people, but it wouldn't be appropriate to just give to everybody, right? Because it's got a cultural lens to it. So I really like this imagery because you can see through an equality lens, the guy on the left didn't need those services. It's serving the one in the middle pretty well, but the guy on the right is still underserved. Through an equity lens, we recognize that sometimes we need to do things differently for some populations. There's a cultural context and there's a knowledge context that needs to be taken in mind. So I'd been showing this image for a number of years, and a few years ago, someone sent me a picture I think is just brilliant. And the question is, what is the fence doing there in the first place, right? Do we need the package of services to overcome the barrier, or do we just need to get rid of the barrier? And I would put forth that one of our biggest systemic barriers is our lack of representation when it comes to medical and health sciences training. We need more of our own people developing the curricula, delivering the curricula, and leading the institutions. So if we were to look at liberation and overcoming those systemic barriers, that's part of our solution as we move forward. So thinking about the next steps for Indigenous health, and of course I work in a university and focused on academics, we really need to think of Indigenous health as an academic discipline. The exposures to risk that we have are very different and unique. The whole idea of colonization, right? Having colonization, marginalization, discrimination, racism, all of these challenges that we face have unique health outcomes for Indigenous peoples. And this became very obvious to me, about 15 years ago. I was asked to present on a panel on Indigenous diabetes, the International Diabetes Federation. And they were having a conference in Melbourne, Australia. So there were going to be 3 of us. I was representing the US, then there was an Aboriginal Australian physician and a Maori physician from Aotearoa from New Zealand. And we had never met before, and we didn't coordinate, our presentations. But on this panel, we gave essentially the exact same presentation 3 times in a row, whether it was American Indian, Aboriginal Australian, or Maori, because the long-term outcomes of colonization have a common element, and we see higher rates of diabetes, higher rates of self-medication and addiction, higher rates of poverty, and all of the outcomes from poverty and marginalization. So we have to understand that we have a unique story as Indigenous peoples, and it has an impact on our health. But what that also says is that we need to have unique solutions that are culturally based and relevant to our people. So there are Indigenous health training programs. I've been very fortunate to work with several of them. I'll talk about those. And then we also need to think of Indigenous medicine as a clinical science. A long-term goal, probably not in my lifetime, but one thing I'd love to see, maybe when I'm looking through an ancestor's eyes, would be Indigenous medicine actually as a clinical discipline. What if someone finished medical school and they could do their residency training in Indigenous medicine? Wouldn't that be beautiful? And that's exactly what our people need. Blend together the best of modern science and Indigenous knowledge and actually come up with solutions that are meaningful for us. Not just the broader community, but actually meaningful for us. I'd love to see Indigenous medicine recognized as a clinical science. And then finally, the idea of an Indigenous School of Medicine. And I'll talk about that in just a bit. So I've been involved in a few programs. When I was at University of North Dakota, I was the Associate Dean for the medical school. And also, we developed a new Department of Indigenous Health. I think there's only a couple of medical schools in the US that have a Department of Indigenous Health. But we started an MPH and a PhD program in Indigenous Health. And when I was proposing this, that we'd develop a PhD in Indigenous Health and really understand Indigenous methods for research, principles of Indigenous health, Indigenous methods for evaluation, and all of these public health disciplines and research methods taught through an Indigenous lens, there was pushback. There were people who said, oh, there's no market for that type of a training program. So I'm very pleased to say that they'll be starting the 6th cohort of PhD students, and they've matriculated 78 students in those 6 years into the PhD in Indigenous health. Thank you. I was also, at that time, able to serve as the director of what's called INMED, Indians into Medicine. And INMED has been around for 50 years, and there's a separate program and process to matriculate American Indian and Alaska Native medical students into that program. So UND, I think, does a good job of working with Indigenous peoples and focusing on medical training. So the way I look at it, there's kind of 4 tiers of medical schools. The first tier, the lowest level, is the medical school doesn't do anything for Indigenous students, which is the vast majority of medical schools. Then there are schools that have programs like INMED. They're at least trying to do outreach and incorporate some cultural support. Then the third tier is actually a medical school located in Indigenous communities. And we have one of those in the US. Oklahoma State University has an osteopathic medical school that is located in the Cherokee Nation in Oklahoma. But it's still governed by the state of Oklahoma. So the 4th tier, the highest level, does not yet exist, but an Indigenous governed medical school. That's both Indigenous in terms of governance, faculty, students, and staff, and communities, but also indigenized in terms of the curriculum. And I'd mentioned at Johns Hopkins, next year we'll have both the MPH and the DRPH in Indigenous health. But let's think about this, an Indigenous School of Medicine, ISOM, Indigenous School of Medicine. What could that look like, and what might that entail, and how could we actually make this come to fruition? Well, let's first start with the data. Quite often when we're developing new programs, people want good data to understand what is there really a need. And we have plenty of data to prove that there's a huge shortage of American Indian and Alaska Native physicians. So we are nearly 3% of the US population, and we're 0.56% of active physicians, and 0.48% of medical school faculty. So when we think about this, we're trying to recruit American Indian and Alaska Natives into medical school. But when they get there, who are their role models? Where are the cultural supports? And that typically doesn't exist. And I would guess it's probably very similar in Canada, right? That we don't have enough of our own people in those leadership roles. So we know there's just a terrible shortage in the physician workforce, and particularly in medical school faculty. Very similar pattern here in Canada. This is from the Canadian Medical Association. So First Nations peoples are about 4.5% of the population, but less than 1% of physicians. So again, underrepresented. And we know the data prove that when there's cultural concordance between the physician and the patient, we see better quality of care, better communication, more satisfaction with care. So this isn't just about diversity and inclusion. It's not just about affirmative action. This is about quality of care. This is a quality of services issue because we don't have enough representation in the physician workforce. So there's a model in the US to think about how we might be able to develop a network of Indigenous medical schools. And that model is the historically black colleges and universities, or the HBCUs. And they have colleges and universities across the United States. Within their network, they also have 4 medical schools. So there are 4 HBCU medical schools in the United States. This is a map of the tribal colleges and universities kind of all over the US. And this is a map of the tribal medical schools. Every single one of them, right? Yes, there are none. There are none that exist at this moment. So is this a problem? Is this something that can be solved or should be solved? And many of us have been working on this now for a few years. And we have goals for the Indigenous School of Medicine. We need to grow the Indigenous medical workforce, but we also need to develop culturally adept physicians. So the school would not be just for Indigenous peoples, but people who have shown real commitment to Indigenous populations. And we need allies, right? And we should be celebrating our allies who are non-Indigenous, but they should be able to go to a school that's actually culturally relevant for our people. And then we will advance Indigenous health and health care. It'll be a culturally integrated curriculum, so the students can learn from elders and traditional healers. And the idea is to have medicine men and medicine women on faculty, not just as cultural advisors, but actually on faculty and helping to teach our future healers. We will incorporate traditional medicines, traditional beliefs and practices, land-based healing, the role for ceremony, the role for language. We'll have ceremony as part of this. And also recognize that we have to work closely with our Indigenous communities as well. So the focus for the curriculum will be on Indigenous medicine, but also it will be an accredited medical school. So again, we'll bring those worlds together. So we also want to support the students. In modern medical training, there's this idea of education by humiliation. I don't know if you've ever heard that term before. But the old way of medical education is kind of break down the student and then rebuild them up into this cookie cutter model of what a doctor should be. Is that good for our people to unnecessarily traumatize young minds and young people? And it's just ridiculous what we do in modern medical training. So when we're focusing on kind of breaking down the student and rebuilding up into this cookie cutter model, that's not good for Indigenous people, but it's not good for medical students in general. There's a study a couple of years ago in the US that showed 26% of current medical students regret going into medicine. Isn't that terrible? 1/4 of the future physician workforce already regrets going into medicine. If they are regretful and traumatized, does that have an impact on the quality of care that they provide? Well, absolutely. And I would put forth that our people have enough historical trauma to deal with. We don't need to add artificial medical education trauma to that equation. So we'll have cultural practices, role models, and mentorship, but also focusing on wellness of the students. And what we want is healed healers, right? And what I see in medical education is that we're graduating traumatized scientists, but we need healed healers. And why? Because healed healers heal, right? We'll provide higher quality of care if we have healed healers. Thank you very much, appreciate that. So the vision is achieving health and well-being through culture and community with a focus on Indigenous health as an academic discipline and clinical science, community-based, and it'll be an Indigenous research epicenter. We have so much to offer the world in terms of healing processes and outcomes that needs to be a part of it too. And then eventually looking at medicine from a broader perspective, not just MD programs, but an Indigenous School of Medicine should have nursing and public health and all of the therapies and counseling, all of those things within one area to learn these things. We did a study with American Indian and Alaska Native medical students, and it was just interviews with them, and they were very supportive and inspired by this. And just some of the quotes from the current medical students. One said, "It would mean not losing touch with my heritage." And isn't that awful that when you go to medical school, in many ways, you have to check your culture at the door and then just become a colonizer's doctor? That's not the way it should be. Another said, "It would ease the pressure, feeling like I'm representing all of Native America." For those of us who've gone to college or graduate school, how often does that happen? You're the only Indigenous person in the classroom. Suddenly you have to be the expert on everything. Should we be adding that pressure to our students? In Albuquerque, New Mexico, there's a huge powwow called Gathering of Nations. And one student said it would be like Gathering of Nations for medical school. Another said they'd feel more at ease, more confident, they'd feel seen and validated, and then for the first time in their life, feel like they're part of the majority. So this is our vision for it. We have now established our 501c3, our nonprofit corporation. We have a team of wonderful Indigenous physicians that are leading the way. Dr. Allison Kelleher is Koyukon Athabaskan from Alaska. Jonathan Baines is Tlingit from Alaska as well. His MD and PhD from Mayo Clinic. Ken Bernard is Turtle Mountain Ojibwe, and he has his MD and MBA from Harvard. Lala Forrest is currently a psychiatry resident at Yale. And our coordinator is Loretta Graycloud, and she's from Lower Brule and Crow Creek communities in South Dakota. So we have our official nonprofit status, and we've been working on acquiring grants for a feasibility study, and happy to report that we'll be starting a large comprehensive feasibility study in August. So in 2 months, we'll be actually officially kicking off the feasibility study. And one of the questions is, well, what will be the location? Where should this be located? And it needs to be in a city large enough to support a medical school, because you need clinical training, so it has to be hospitals. Ideally, a city where there's not a current medical school, because there's always pushback from the existing schools for clinical training competition. And then also, ideally, a place where there's a lot of Indigenous patients. So we've been looking at places like Rapid City, South Dakota, and Anchorage, Alaska. But long term, what we would love to see is Indigenous School of Medicine campuses all over in the world in Indigenous populations. Why not have a campus right here in the future in BC of an Indigenous School of Medicine where we share curricula, we share knowledge, we learn from each other, and we create that future in the next generation where we see improved outcomes. So just to close with a couple of thoughts, one of my uncles, who's a medicine man, described the way that we live in a very beautiful way. He said that there's nothing we can do to change the past, right? We can't change the past. But there's everything we can do to influence the future. And the miracle of now, this very moment in time, where the past meets the future, is right now. And what we choose to do will have an influence on the future. Each of us has that power. Each of us has that control. Isn't that remarkable? What a beautiful gift. And if we choose to, we can decide to make the world a better place for future generations. We also learn a lot from our animal brothers and sisters, and we know that the Bison Nation in Lakota de Pteoyate, the Bison Nation, we know that the strongest bulls face the storm and protect those behind them that are more vulnerable. And we can learn a lot about that. I think all of us who are in these roles and leadership positions, we have that responsibility to protect those around us. So let's just agree that we can work together to make the world a better place for future generations. And I would love to work with you here in BC and in other parts of the world to do exactly that. Pilama yayalo, mitakue oyasi. Thank you all very much.